Unstable Vitals is the podcast that takes the pulse of American healthcare, and the prognosis is critical. Doctors Laura and Adam, former ER physicians turned entrepreneurs and business leaders, expose why the system is unraveling before our eyes. But all hope isn't lost. Laura and Adam cut through the noise, spotlighting what's failing, what's actually working, and what it will take to rebuild a system on the verge of collapse. Buckle up. This is the unfiltered, no BS conversation healthcare desperately needs.
Hey, Laura, it's good to see you.
Hi, Adam.
It's so nice to see you.
Likewise.
Where in the world are you today?
Today I sit in New York City. I am heading back to London tomorrow on the day flight so that I can get lots of work done.
You know, I've never done that day flight before, but I hear it's pretty awesome.
It is, because the flight back is too short, and so you would land in the morning trashed. But if we get up at like 4 a.m. tomorrow and I have work downloaded and I work all day, and then I have my regular end of my day, glass of wine at 6 p.m., home bed.
Yeah, I mean, it kind of works out. So I don't love the overnight flight to London. It's way too short. It's almost like if you take a sleeping pill, Ambien, you still wake up a little amnestic.
You might wake up actually back in New York because you will have missed the disembarkment.
Yeah, that's true.
Where are you today?
I'm at home in DC in my home office.
DC, what's happening in DC, man?
Nothing.
Nothing.
Okay. Nothing and
Nothing.
everything.
Boring.
Everything.
There's no news at all coming out of DC.
None. I mean, only about 200,000 people, I think, has been estimated, has been fired or released out of the government.
But that happens on a regular basis anyway. I mean, there's nothing, what's the reason for all that, Adam?
Yeah, I think the new administration is somewhat thinking like, hey, let's just cut waste. And so we're going to get rid of our most experienced,
it's kind of brilliant. If you
hires.
just don't employ decision makers, no decisions will be made.
That's also true. And no, in all honesty, it's actually pretty a sad day. I mean, I've had several friends lose jobs recently, and so sometimes all you can do is try to look, smile, and kind of grin and bear it. But it's not. It's a pretty bad time. I mean, we've lost several really important people at the CDC, the FDA, Medicare and Medicaid. Of course, USAID has been shut down. So there's really not anyone that I interact with on a frequent basis that's not affected by this. And so it's a day.
And you're in DC. Outside of DC, I was having brunch on Sunday with a friend who has a government-sponsored funding for her startup, and they just fired her program manager's boss. So are they going to get a check? I mean, you have to have somebody hit the send button in order to get the check.
Yeah, there has not been any clear kind of rationale other than the fact that 2 weeks ago they released hey, you can resign early and have deferred resignation until September, but that even has faced legal challenges. And then some people that signed it, they said, oh, just kidding, you actually can't leave, because it's at the discretion of the department heads.
Do you know what this is like? It's like, I always wanted children. And then when I got them, I said, this is a bit like living in a halfway house for abusive alcoholics, right? Like, I love you, I hate you, I'm going to punch you in the face. Please forgive me, mommy, I love you so much. And that kind of like insecurity about what you're facing, that creates some real trust problems. I feel like the government's becoming an abusive alcoholic.
Well, what's worse is that what happened this past weekend in DC, tens of thousands of government employees who were recently hired into some really difficult positions. And I know this from personal experience, but there have been multiple different positions within the U.S. government that have taken months and months and months to hire into because they're looking for specialists that understand healthcare policy, or they're physicians, and they have to get out of their clinical job to come work for the U.S. government or have some type of partial job. And so you have these individuals that have been hired, brought into the U.S. government. that are doing a public service, making much less actually than they could make in the private sector. And there's several that got termination letters. And here's the kicker, Laura. The termination letters weren't just, sorry, we're having a reduction in force and, there'll be an offboarding period. The letters, as CBS reported, were cruel. They talked about how people were incompetent, that you're incompetent, you didn't meet the competence necessary to maintain your position in your probationary period. And so you've got these physicians who have been and attorneys and PhDs and specialists that have worked their lives to be in a position like this, to only be told, hey, you're not competent, but it's clear it's not true.
Well, and that's just, that's just so they can defend the decisions. But anyway, so why are we talking about all this, Adam?
We're talking about it because, our health policies dictate health outcomes. And when we have an emerging bird flu crisis, that's why the price of eggs are so high. You see complications between the growing I can't even talk. The growing.
You're so distraught.
I know the growing consolidation of the healthcare industry, and what is the role of the FTC, and do people have adequate coverage, and are physicians getting the right reimbursement levels from Medicare and Medicaid, and what type of funding is going to happen to Medicare and Medicaid? Are they going to cut funding? The system is unstable, and that's why, and it was unstable before, and we surely are thinking that there's some instability there now.
Well, and I think a lot of doctors are feeling under attack,
and
a lot of scientists, and a lot of people, most people are good and they want to do the right thing, and none of us went into medicine to become trizillionaires.
No, that's right. So why are we doing this? I come from a healthcare background, health executive at a healthcare company, physician, and now running my own company, an entrepreneur. Of course, I teach at UNC, and that's how you and I met when teaching.
Right. I am too a doctor who decided to get an MBA so I could understand what the heck is going on in the world. And when I signed up for your class, I thought easy peasy challenges in healthcare. And it turned out I didn't know anything.
I think we both grew up in this silo of what we thought healthcare was, and it was mostly surrounding hospitals and doctors and nurses. I don't know if you've seen the old Airplane movie, what's that? What's a hospital? But it kind of was in that space that we understood healthcare and not anything outside of it. And man, you take my class, I prepare for that class, you see that healthcare, who knew it was complicated, right? And who knew there were some challenges. So we wanted to talk about these things, pull in some guests, have conversations about, the instability of the healthcare system, but we didn't want it to be all doom and gloom. And so we wanted to call it what it was. It's unstable. But yet we are ER doctors. And that's our specialty, is dealing with instability, dealing with an unstable patient.
Love it.
Unstable vital.
We're adrenaline junkies. There's nothing I love more than a real crisis.
Right, exactly. It's managed, it's chaotic, but yet it's managed chaos.
That's right.
And so, if we said healthcare's dead, then that's not really, can't do anything with that.
No, dead is dead, right? That's the black tag during the triage.
That's exactly right.
We wanted to put a red tag on the toe of healthcare in America.
100%. We wanted to say, hey, it's unstable. Let's not pretend that it's stable. Let's call it what it is, but also understand that there's ways that we can fix it. And we want to pull some people in to talk about these unstable vitals.
People
we need
way
to do.
smarter than us. People
way
smarter than us.
It doesn't take a lot.
No, it's really low bar.
Right, low bar. So that's what we wanted to do. That's how we came up with the name. And but why are we the ones kind of hosting this or talking through this, Laura? What's your story?
Unstable vitals. First off, I'm pretty unstable, and secondly, I like to hear my own voice. So I think right there,
great reason.
I am a doctor. I think I'm relatively amusing. I'm a middle-aged woman, and therefore I carry both authority and a lack of caring of what other people think of me anymore, right? I'm 53 years old. Get out of my way. I'm going to say what I'm thinking. Middle-aged women tend to lose their filters, and I'm unstable, filterless, and well-educated. So I thought that was just, a good place to start.
I think that's a great reason. If you look at the other podcasts that are out there these days, I mean, you got lots of people that don't have anywhere close to our level of our level of expertise. And from there, they're talking about all kinds of things. And my hope is that people will take some of the things that we're talking about, and some of the guests that we have on, and recognize, oh, there is a lot of information that we can talk about with credibility and
And
trust.
I think you are uniquely suited to this as well, but do you agree?
Oh, sure. It's just because I've red glasses. That's the reason. It has
I put on
nothing.
yellow glasses for you
Yeah,
today.
I like them. But no, I think so. I mean, my background is such emergency physician. I was a healthcare executive, one of the nation's largest healthcare provider companies. Managed a service line that was worth $2 billion in revenue, oversaw a COVID response, and then started my own business. And I think one of the most exciting things really was teaching at UNC, teaching in the MBA and EMBA programs there, now also teaching in Europe. And so I think that a lot of the students and the business school ESCP in Europe saw, okay, if we want our students working in pharma and in device, and UNC saw something similar, if we want our students to interact with the healthcare system, and everybody does if you live here in the US, they need to understand who are the stakeholders, what are some of the drivers, what are some of the incentives, and problems that are happening. Because you made a comment earlier, like we didn't know that healthcare was as complicated as it was. We were focused mostly on just the day-to-day medicine. But once you start to peel that onion and you look at all the different pieces of the healthcare system, it is quite broad. There's a lot that's going on.
Well, and I think what we're trying to do here is we speak two languages, right? So I'm a pediatric ER doc, right? I did not go for the smelly old people. I went for the screaming young people. Pediatric ER doc, but I've had the opportunity to practice. I trained in the US, I practiced in the US, and then I moved to the UK and I practiced within the NHS. And so, like you, I've seen different systems. And you and I both speak two languages. We talked about that. You start medical school and all of a sudden you've got this whole new vocabulary, like, pylorus. Oh my God. Right. And then you go to medical school and I'm like, what the hell's a Kager?
Mhm.
Is that like a Kegel? I don't know.
No, it's totally different.
So when you can speak both languages, I think that we're in a unique position to translate the incentives, and the misalignment of incentives are happening on both sides. They're happening within medicine and they're happening within healthcare as a business, as a for-profit business in the United States and elsewhere in the world, right? The US is not the only place that has, for-profit medicine. And I think people will be surprised to know that there's for-profit medicine in the UK, you know?
Exactly. I mean, the NHS is the National Health Service is such a big part of the conversation in the UK. It was a big reason why Labour won, this past year. But the UK is struggling because of the funding for the NHS, and they're starting to look at public-private partnerships and in the private sector. And even, are there things that can be learned from the United States? Also, and that learning can be, what can we learn that works, but also what can we learn that doesn't work? So I think that there's a lot of opportunity for us to bring in some of our different colleagues and friends and people that we've worked with to help inform what not only are some of the problems, but how to fix some of the problems that are out there in the United States as well. I mean, Laura, this is kind of off the cuff, like if you were to think about the United States healthcare system, how would you describe it right now, other than unstable?
That's a really great question. And I guess I'm speechless. My
Mm,
answer is speechless. You
mm,
know, when I was a little doctor, I went into medicine because I wanted, we all share some combination of intellectual curiosity, basic intelligence, a desire to help people, and an element of ego, right? Like I want to be a doctor. But none of us go into it really understanding what we're getting into,
mhm.
right? The politics, the different stakeholders, it's really not fun to wake up in the middle of the night. Like nobody likes that. Nobody wants to be called and woken up in the middle of the night for anything, right? No matter how important what you're doing is. And then, I left the US 18 years ago. And so my transition, it wasn't great when I was a little doctor. I saw problems with it then. Fast forward to having been outside the United States and, my mother became ill a few years ago, and she had, ALS, motor neuron disease. And my father's a doctor, and my mother's a nurse, and we could not get her into a neurologist for 6 months. And so I ended up having to call favors and fly my mom to another city to see a neurologist in a timely manner. And that to me just was so eye-opening, that how things have changed from, we used to have these professional courtesy calls, and it feels, I guess, more, and I
Corporate.
and you tell it feels more corporate, and it feels like people who are trying to do the right thing aren't being allowed to.
Mm. I think that's a really good point. When I talk with colleagues about some of the challenges, of course, burnout comes up a lot, and we are going to talk about that. We're going to talk about how a lot of physicians have shifted careers, or clinicians in general, nurses, technicians, administrators, to identify how can they still tap into that desire to try to help people, but yet not face some of the issues that they face with burnout. But I believe a lot of the reason why is that loss of autonomy, that kind of moral injury that occurs between knowing what should be, for the care of the patient, and then knowing and then experiencing what is, and then believing that in some way you are responsible, because just by default of you being within the system. And so it's a real challenge, I think, for clinicians right now within the healthcare system. People have asked me how I would describe it, and I would say it's unstable. And I say it that way simply, the healthcare system is unstable, and I say it that way because, can you go to a hospital to get care? Can you go to an emergency department to get care? Yes. Do we have some of the most innovative drugs and devices in the United States? Yes. But the accessibility of those devices or those drugs is very, very disparate. And you have some groups of people that have great long lifestyles, or lives with great ability to access healthcare. You have others that have very limited access to the healthcare system, even though they may all have insurance, or they may have some different type of form of insurance. And so we'll dig into those. And I think those are playing into how the system is not as stable as we would think that it should be, considering that the United States spends more than any other country on the healthcare system.
All very good points. Agree with all of it. I think that there's another way also for us maybe to address some of these issues, which is pointing out to the people who don't understand medicine, who think that they're coming up with great ideas, but actually those ideas, cost cutting contributes to the instability. And how do we get private equity and private investment to understand that this is a long game, and short-term cost containment is probably not the best investment strategy in this environment, right? Like, you cut costs, you're costing lives.
Oh,
But if you could
exactly.
look at medicine and healthcare in as a long game, and you bring in people who understand the medicine and the consequences that might be unforeseen, then maybe everybody wins, right? Patients get better care, doctors have better experiences, and the people who are looking for an investment, because at the end of the day, that's what people want, they can win too.
Exactly. And the other thing we'll talk about are politics. And I know that there's folks that will say, oh, medicine should have no politics. If you say that, then you fundamentally don't understand how the system of healthcare is funded, where the majority of our patients, or the majority of our healthcare dollars, come from some form of public insurance, whether it's through Medicare, Medicare Advantage, a public-private partnership, whether it's Medicaid, managed Medicaid, the VA system, TRICARE. All of those different types of pieces of the puzzle come together to fund our healthcare system. But the decisions on reimbursement, what's covered, what's not, who gets benefits, who doesn't, what is the threshold for poverty level for Medicaid, those are all political decisions. And that's something, they're inextricably linked, where the health policy is tied to healthcare and the outcomes. I mean, we saw that during COVID. that if you were a governor of a state and a legislative body in a state that did not support mandatory vaccinations and masking, your death rates were higher than other states that had mandatory vaccinations. And so one could say, well, let's keep the politics out of it, but that was a political determinant of someone's health. So we'll
Well,
discuss that.
yeah, and I think, politics can mean the politics of the current administration, but it can also, I think we need to get into some of what people really may not understand about the politics within research, within innovation, within even what gets published. What are the drivers behind some of the conclusions? There's been things that medicine's gotten wrong.
Mhm.
And we've been very slow sometimes to change because of the political knock-on effects. We have national organizations that doctors pay a lot of money to be members of, and they want to control for a variety of reasons. And some of that is to curry political favor with the government, what message patients are hearing. So there's no way, I mean, even the politics of just how you get promoted in academic medicine.
Exactly. Or the cost of recertification, or the cost of licensure, or the cost of residency, the opportunity cost. I mean, a great thing for that would have affected you and myself is the length of time for an emergency medicine program. That's being debated right now of whether or not it should be longer instead of shorter. But that's against the backdrop of more nurse practitioners and physician assistants working within an emergency department, and against the backdrop of uh, high rates of burnout within the profession of emergency medicine. So I think there's a lot for us to discuss here. Obviously, you and I don't know all the answers. Oh, well, you probably do, but
No, I know no answers. I told
okay.
you low bar. We're going to
Yeah,
talk
so
to
so
smart
we're going
people.
to pull in some people that do understand this, and can talk through some of these issues. So
I think
I
that's
think we've got a lot to do, and we got a lot to talk about.
well, and I love the name. Can we explain how we got there?
Well, I mean, we tried a whole bunch of different names, and we tried everything from like Code Brown. Partially that's because my last name, but also because like that means that
You know
it's a
what?
shitty situation in the
I
ER.
just now got that.
Yeah.
I
Well,
loved Code
what?
Brown because that's, in pediatrics, we don't even call it because all our patients shit themselves.
Yeah, well, I know. So like that's the thing is that when they would call a Code Brown in the emergency department,
You'd
that was
come
like
running.
no, that was sometimes I was jokingly called a Code Brown because I tended to be a black cloud that would bring in some of the worst situations, although I managed them fairly well. But the worst Code Browns were really when you have a, let's say, a shitty situation. You know what, side note, I'm going to tell you a funny one. One night, I'm working overnight in Danville, Illinois, and I was the overnight doc in the emergency department. And all of a sudden, I hear a patient screaming from the bathroom. And so we go in, and like, you don't want to hear screams from a bathroom. So, me, the nurse, like several of us, security kind of go up to the bathroom, make sure everything's okay. And she was fine, except for the fact that the toilets and the sinks were backing up with brown goop. Okay. We know what that was. So
Oh,
very
oh,
shortly thereafter, brown gunk was coming out of the other rooms that had drains in them, the trauma bays, etc. So we all of a sudden called an official code brown in the emergency department. Um, because it was quite a shitty night in the ER. And then we called the plumbers, the house supervisor. We brought down these portable water machines. It did not smell very well. We blocked off rooms that were kind of having backup and sewage issues. It was a bad situation. And you know what the situation was caused by? We had a psych patient that decided to
you
flush.
had Indian food.
No, that was not not the situation.
No? Okay.
But what was the situation is we had a psych patient who decided to flush her brassiere and her underpants and an undershirt down the toilet and clogged up the main system. And so it backed up throughout the hospital. So,
Well, I think, okay, you're definitely Dr. Code Brown, and I am such a black cloud when I was a trainee. I'm
mm,
such a black cloud that one night I was in the trauma ICU And, I'm a pediatrician by background, so but I had to rotate through the trauma team for a month as a fellow. And the nurse comes over. I'm sitting there with my senior surgical resident, and the nurse comes over and says, there's been this major catastrophe on a freeway, and they don't know how many victims yet. And we need to start clearing out the trauma intensive care unit to make room for incoming patients. And she's giving us this whole report, and my senior's listening to it, and he just freezes. And this is the part where we should remind people that we like to use lots of words that maybe little ones shouldn't hear. So take the children out of the room now. So my senior just stares at the nurse for a minute, and then he turns and looks at me, and he says, "Fuck you, Zibners."
Totally blaming all the black cloudness on you. But here's something else that just happened. What just happened was the fact that we were talking about how we came up with a name, and then we went on a rabbit trail about Code Brown, my fault.
Right.
And now we're back. And so
we're back. Hi.
We came up with Unstable Vitals. We came up with lots of names. But it's like we said at the beginning, the system is unstable, but it's not without hope.
That's right.
So whenever we have a patient that comes into the emergency department, they may be really sick, and we determine whether or not they're sick, oftentimes based upon their vital signs. Mm-hmm. And if they come in sick with bad vitals, you and I want to fix that. That's our goal. We want to give them the IV fluids, the pressors, the medications that they need to get.
We want to call the smart people who will care about the detail and do the detail. We're the ADHD doctors of the hospital.
It's true. Diagnosed. Yes, diagnosed.
Me too.
Yeah. But that works well for us. And we're able to focus really, really when that adrenaline is pumping on a really serious issue. We fix that vital sign to get that body stabilized while we're calling in the experts to come and help.
That's right.
So
they can Monday morning quarterback everything we did wrong.
Exactly. Except for the fact that usually the body of the person is still alive and they are talking to, and then they'll complain about what we did. But that's a side note. That's
side note for another day.
Yeah.
Well, I'm in a hotel now, and I hear that they've got the vacuum outside my room. So
that, I guess that's a sign that you need to skedaddle.
Everything else we talk about, we'll check in every week or however often we manage to do this. We're procrastinators as well, but if we take our meds, we should be okay.
I think
we'll talk about our companies, what we're doing, what we're seeing, take a little pulse, and then invite smart people on to talk about what's next.
I think we've got some cool guest stars that already want to talk with us. So that
would want to talk to us. I want to talk to us.
I would want to as well.
Right.
Sometimes my husband doesn't necessarily want to talk to me. That's not true. But
that's a you problem.
That is. But well, listen, I hope you have a wonderful day flight back to the UK, back across the pond.
I hope that something exciting happens in DC. I mean, just anything. Maybe there will be a cat stuck in a tree, and that will make the news.
Sometimes we have bears. We have bears that end up kind of in not normal places, like in the middle of someone's backyard. So that's kind of fun news.
Is that like a real bear, or like a panda bear?
That's fun news, like a black bear. Yeah.
Black bear.
Yeah. Or a brown bear. I don't know.
No, there's a difference. Brown bears are meaner. You stand up to a black bear and you hide from a brown bear, I think, is the rule.
I mean, this again is something I learned.
But even black bears are often brown.
I just want to.
We've come now full circle.
Yeah. If I saw a brown bear, that would be a code brown.
That would be and it would be a code brown in so many ways. So
many different ways. Well, with that, it was good talking with you.
It was good to talk to you. I can't wait to do more of this.
Talk with you later. All right. Okay.
Thanks for tuning in to Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit unstablevitals.com to stay in the loop. And don't forget, real change starts with real talk. See you next time.